All right, so welcome everybody. I think people are joining us, but I'd like to get us started because we have a full program for the second webinar of our Household Food Insecurity webinar series, hosted by the Office of Lifelong Learning and Physician Learning Program at the University of Alberta. My name is Denise Campbell-Scher. I'm the Associate Dean at the Office of Lifelong Learning and Physician Learning Program. Our office is committed to providing reliable updates, resources for clinicians and healthcare professionals, and everyone committed to addressing the challenges relating to food insecurity. We'd like to acknowledge today that we're on the traditional territories across Canada of the many First Nations, Métis, and Inuit, whose footsteps have marked these lands for centuries. So there's a few items I'd like to go through. First of all, please have a cell phone handy if you don't have a second monitor, as there'll be some interactivity using the Slido app. So if you have a cell phone, please have it at the ready. And if you have chat questions for the technical issues for L3, use the chat feature. But also, if you have resources that you'd like to share in the discussion period, please pop them into the chat feature so we can capture them and make sure that they get circulated when we circulate our Pearls document and recording. If you have any questions for the speakers, for that, please use the Q&A feature of the webinar. And please review what's already been asked and upvote those questions you'd like to have answered. We can't necessarily guarantee that panelists will be able to respond to all of your questions, but we'll certainly capture them and try to respond to them offline. A recording of the webinar will be sent to all those that registered via email. You can claim CME credits through completing a personal development activity using the My L3 Plan tool. And so if you scan the QR code, it'll take you to how you can do that process. This activity has not been formally reviewed by the CFPC or Royal College. However, it's eligible for non-certified credit. And those who are in the Main Pro Plus program can also earn additional certified credits by completing a linking learning exercise. So today it's my great pleasure to welcome Dr. Ojedokun, Kally, Cheung, Lacey, Smoole, and Shawna McGhan, who are going to be sharing with us today the importance of using an integrated approach to support patients experiencing household food insecurity. And they'll be joined in the Q&A portion later on with Dr. Luanchuk, who you met last time. The topic for today is strengthening foundations for patients facing household food insecurity, experience of a primary care clinic. So I'd like to start by introducing our first speaker, Dr. Ojedokun, who trained initially in surgery and then family medicine in Ireland prior to moving to Whitecourt, Alberta about 10 years ago. He understands that change is inevitable in the current social and healthcare landscape, but that not every change leads to an improvement. Dr. Ojedokun's passions lie as a rural primary care physician. He believes in positive change through true advocacy, change that involves the people, patients, physicians, support staff, and the whole community. In his 23 years of practice, Dr. Ojedokun has contributed to various initiatives, such as the recent Alberta Surgical Initiative to improve healthcare systems. As an early adopter, he is practical and realistic and believes his influence on a network of primary care physicians as the North Zone physician champion affords him the opportunity to add valuable practical wisdom to this initiative. And Shawna McGhan, we welcome back this week, as a master's prepared registered nurse who's worked in chronic disease management, primary health care, and now health system integration within the provincial portfolio of Alberta Health Services. She's been working to support a health creating system that collaborates and learns alongside health teams and communities and sectors. Using human-centered design, she's been exploring innovative approaches to enable system change around social determinants of health in partnership with primary care and community. She's been an integral part of leadership teams on projects like reducing impact of financial strain and patients collaborating with teams. Previously, she led innovation initiatives, research, and publications at the University of Alberta's Asthma Centre for over 20 years. Kally Cheung, we welcome back this week, is a public health nutrition provincial lead with Nutrition Services, provincial strategy team at Alberta Health Services. One of her focus areas is to build understanding of household food insecurity in the Alberta context and partner with health teams, care providers, community groups, and researchers on actions to support those experiencing household food insecurity. She's a registered dietitian and a certified diabetes educator and has a master's of public health from the University of Alberta. Prior to this role, she practiced in clinical areas such as pediatric nutrition, diabetes, and eating disorders, and in both rural and urban Alberta. She also supported research in Indigenous communities on nutrition and food environments. Lacey Smoole has been practicing for over 15 years as an RN and providing care at the primary care level for over 10 years. She has a special interest in chronic disease and navigating barriers for these vulnerable populations to improve quality of life. As part of the quality improvement team at Life Medical Clinic, she takes a patient-centered approach to creating capacity for vulnerable conversations in efforts to address root problems that may be contributing to poor health outcomes for our patient population. So with that, I'd like to thank everyone for their participation, for their time, and welcome everyone to the webinar.
Okay, thanks Denise for the introduction, and thank you all for joining us for the second webinar of the series. Let me just put on my presenter mode here. So at the last session, we reviewed the AHS nutrition guideline and resources for working with patients experiencing household food insecurity. As household food insecurity is rooted in financial strain or lack of money, knowing about whether a patient is experiencing financial strain can help direct our care plan, the resources that we connect them with, and conversations with partners about how to support patients in the community. Today's session will focus on practical application of the resources for your practice. We will begin with a case study and then hear from Lacey and Dr. Ojedokun about how they shifted their practice to talk about financial strain. So we'll start with the case study. And this case study is actually, Lacey and Dr. Ojedokun's experience with a young man named Mark who has diabetes.
I remember entering the consult room one morning and greeting Mark, who wore a big oversized toque and a giant smile. As usual, he seemed engaged and eager to manage his diabetes better. But after a whole year of working with him, nothing had changed. His blood sugars were still wildly out of control, and his eating habits were poor. I really wanted our discussion that day to be different. I didn't want him to live the rest of his life with the potentially terrible side effects of unmanaged diabetes. As we started reviewing his home readings and recent lab work together, I knew that things were still the same, if not worse. Have you been taking your insulin? Or have you forgotten any doses? Nope. I have been using the long-acting and taking my short-acting with meals. Okay. What have your meals been looking like? Well, I usually skip breakfast, but I always have a good supper. Do you snack throughout the day at all? And what do your suppers typically look like? No, I don't really snack at all. and I usually have a big bowl of soup or noodles for dinner. Can you tell me a little bit more as to why you typically eat this way? Well, it's half habit, half necessity. I remember.
So just thinking about what you've heard, this is a self-reflection question. Does Mark's story sound familiar to you? If Mark was your patient, how would you have approached this? So I'll invite you just to take your phone, scan the QR code, or enter in the slido.com web address, and just kind of share your ideas of what you would have done after hearing that. It sounds like a lot of us are thinking similarly, just to explore it a little bit more. Be curious, practice with empathy. And there's a lot of great questions just to maybe just kind of understand the situation more or continue the conversation. Yeah. Just give a few more minutes for people to share. Yeah, it's very just listening and exploring on what Mark's experience has been like. So just for just in the sake of time, I'll just move on to the next slide here, and we'll continue with the story.
Can you tell me a little bit more as to why you typically eat this way? Well, it's half habit, half necessity. Suddenly, it was like the lights turned on in the clinic room as Dr. Joseph and I both stopped and looked at each other. We had been working on a project for the past few months about reducing the impact of financial strain on people's health, and that phrase, half necessity, took on a whole new meaning. We paused for a long time as our treatment plan whirred through our minds. We had planned to refer Mark to a retinal consultant, a healthy living class, a dietitian, and we're already thinking about different interventions we could use to mitigate his progressing diabetic complications. But instead, I turned back to Mark and asked, "What do you mean out of necessity?" He squirmed a bit, coughed, and with an awkward smile said, "Well, I don't have that bursary for school anymore, and I haven't been able to find a job yet. And my mom lost her job recently, so we just don't have a lot of money for food right now."
So now that you've heard that your patient is experiencing financial strain, what would you do? Mhm. Lots of great themes here. Validating and just showing empathy, connecting him to different resources and see what he might be available, what might be available. Yeah, lots of great suggestions. And it's just great just to hear just the wisdom and expertise from this room about what's worked and what they've tried before. It's all really aligned to some of the ideas that were shared in our last meeting. See if I'll just give it a few more seconds just to see if there's any more responses coming in. Yeah, just connecting to services, validating. I just really do want to touch on that point about validating, because I think it's a really important point. Because one of the biggest ways care providers can make a difference is by asking and normalizing financial strain. By understanding what's happening in the patient's life and building recommendations that are realistic for them, you are making an impact. Studies have shown that just the act of talking about financial strain and having it being reflected in the patient's care plan can reduce the patient's stress level. And this is something I hear hints of it, but we didn't really have a chance to fully hear in the story, is just the safe and respectful environment that Lacey and Dr. Ojedokun has set up in their clinic. It's a place where patients feel comfortable about sharing their life challenges and the impact on their health management. In fact, Lacey and Dr. Ojedokun has shared that patients are coming in at a less acute state because they feel comfortable coming to them as soon as their care plan is not working. On your right, the QR code is a link to our nutrition guideline, which provides additional resources on how to talk about financial strain if you're interested. But I want to really there's a lot of wisdom in this room, and I do want to hear from you and your experience about what's helpful. Can you please share your tips for how you create that space to talk about financial strain? Feel free just to even share, your approach in asking the questions or environment you create. Just really curious about what's helpful. Yeah, asking for permission is a big one. Just to really, give that power to the patient. Trauma-informed, judgment-free. Normalizing. Yeah, it's just that's something that's out of control. Non-judgmental, open questions, asking for permission. Thanks so much for sharing. So let's just continue with the story and just hear how Lacey and her team approach the situation.
Over the next month of weekly meetings with Mark, our team helped him apply for Alberta Works, provided him letters of support for various government programs, brought in his sisters to expand his support network, and arranged for his medication coverage. In one of these meetings, we talked about his goals for the future. He had been studying to become a lawyer. He said he didn't come from much, but that he was going to break that trend.
Yeah, to me, this clip really shows the wraparound care that the clinic team provided to build a foundation for Mark to be successful with managing his diabetes. In addition to helping him apply for coverage and income benefits, one of the things that really stood out to me is that the team helped him or brought in his sisters as support. It just highlights the importance of just leveraging existing assets in Mark's network, which can help foster resilience and build on the strengths. I'll review some of the resources from our webinar that might be helpful in this situation. Having hand-to-hand referral for support is really important. But if you don't have access to a community navigator or a social worker with your clinic, there might be community organizations such as the Family and Community Support Services that can help. Or a service agent at the Alberta 211 can also help guide patients to income supports and resources that they're eligible for. Patients may also be able to access extra money for food. So, for example, once Mark is eligible for Alberta Works, he can access special diet funding for diabetes management. So just to give you an example, that's about $44 as of January. And the amount of special diet funding can vary with the type of health condition that a patient has. On our AHS website, you will find a list of funding options for special diets and nutritional products, as well as letter templates you can use to save you some admin time as you're helping patients with applying for special benefits. I'll summarize the case study with this framework that integrates social care, into the delivery of healthcare. And it is grounded in the awareness of financial circumstances that a patient might be facing. And once you're aware, you can adjust the care plan based on the context and assist with connecting to services and supports. You might also look at how you can align the service delivery to better reflect the patient's needs. So for example, extended hours, virtual appointments. And there might be opportunities to partner with others in the community to reduce the burden and financial strain. So we're so pleased to have Lacey and Dr. Ojedokun here to talk about how their team sets up the clinic to lay the foundation for health for their patients. I'll pass it over to Shawna to facilitate the discussion.
Thank you so much. What a great story. It's such a pleasure to dive deeper into this with both of you. I have a number of questions for Dr. Joseph and Lacey, but invite all of you to add your questions into the Q&A. But I wanted to start by just congratulating your team on this amazing digital story and all the awards that your team has received in creating such an impactful patient experience. In the video, you gave us some clues, but I wonder if you could give a bit more insight into why you feel it's important to support social needs like financial strain and food insecurity. Dr. Joseph, I wonder if you want to kick us off.
Okay, thank you very much. I think I really like this webinar, the way it's structured in terms of, I attended the last week webinar addressing what we're trying to talk about here, or we're trying to address, why it's important, and then today, specifically how. And I think the how is very important. So your question there, I think, really addresses the why. And I think most of us already understand why this is really important, but can I just emphasize some of them quickly? I was just thinking about this today. Actually, I saw a patient yesterday in my clinic. I think it was in the afternoon. So I think she's probably in her 40s. She was in the emergency department, I think about 2 weeks ago with chest pain. And, in the hospital, she had troponin, chest x-ray, and all the tests and everything done. Everything was negative. And she came into the clinic as a follow-up to see me, I think about a week ago. And she saw my medical student. And we kind of took it away, took it from there. Your chest pain, well, troponin, everything was negative. There's no family history of heart attack. She was still quite concerned. Maybe she was having a heart attack at the time. So the medical student took a long history, and then we arranged Holter monitor, then stress test, and more tests. And then she came back to see me yesterday. And I was the only one in the clinic, so I was able to sit down with her to have a good chat. What's going on here? What's going on? It was at that time I was able to get to the bottom of the problem. She's having issues with her partner at home. They've been together for about 3 years. She's feeling insecure. He has mental health issues and all that. So the reason why I'm highlighting that story is when we don't highlight and when we don't address, you can't even address something if you don't identify it. When we don't identify and address social determinants of health, patients go to the hospital. Patients come to the clinic often. There's high utilization of healthcare services, ED visits, like I talked about chest pain. We have some of these patients we call heart sink patients. You see their name on your list, you're like, oh, Lord, Shirley is coming again today. It's because you've not gotten to the bottom of the problem. And so that's why this is important. It's costing us a lot of energy, frustration for the patient. dissatisfaction for the caregiver, for the physician. Some patients, doctor shopping, referrals, like you can see in that story, referral to specialists. Some patients have gone through various psychiatrists, psychologists, frequent attenders in hospital or even the clinic. And we really never get to the bottom of the problem because we truly never paid attention to these social determinants of health. It could be loneliness, it could be depression, anxiety, it could be food insecurity, it could be loss of job or whatever. So I think those are some of the reasons I can think of now why this is really important for us to address.
Yeah, wow. Fantastic. Is there anything you would add, Lacey, from your perspective?
Yeah, absolutely. Thanks for that warm introduction to Kally. It's nice to be here with you again, Shawna. It's nice to see friendly faces when we're talking about this great work. I think when Dr. Joseph and I, we were working on this project initially, it was kind of building off of a previous initiative, patients collaborating with teams, and kind of the focus there was what matters to you. Meaning what matters to the patient, what's most important to them. And this RIF's work just takes it to a new level. And I know we're focusing on financial strain as part of this series, but as we were working through, we found that, oh man, like as Dr. Joseph said, those social situations can impact, just as much, if not more, than the financial strain. So we did end up having a questionnaire that included 6 questions that screened for not only financial strain, but also, ability for medications, afford medications, transportation, and housing, which all could be included in that financial strain. But yeah, we were finding that you could see from the story, we had to pull the information out from Mark. He was not going to volunteer it. And I think that it can be part of the stigma that exists, that maybe those are problems that my physician can't help with, or that, that's not part of my physical health. That's not his problem, or, what belief system was, using these tools just creates the capacity for those conversations. This is a screening tool. It's kind of has a certain degree of anonymity to it, where your physician will, just be the one looking at it. And it's a little bit easier for them to disclose, so that you can start unraveling these many factors that are impacting these patients' health, that it's becoming a barrier for them reaching their health goals. And we were finding, yes, like Dr. Joseph said, we're seeing the same patient over and over again. We're talking about the same thing. We're like, why? What's holding this back? What can we do more? We're missing something. And I believe that this was kind of the missing puzzle piece, if you will.
Yeah. Yeah, and I've heard you talk many times about building that culture within your team that reduces the stigma, supports empathy, and is sort of open to that what matters to you kind of conversation. We heard some great example, or we read some great examples through the Slido, but I wonder if you can give examples of that really show us how you inspired the team to shift mindsets and roles and thinking.
Dr. Joseph, are you popping on this one?
Yeah. So let me comment quickly. Actually, before I go in my intro, I just want to quickly say, I was introduced as the North Zone Physician Champion. I'm no longer the North Zone Physician Champion, just to quickly highlight that. Yeah. So you're talking about teamwork, Shawna. I think teamwork is extremely important. So to give you a quick context, in terms of how we work. We work in a 7-physician clinic. It's a group practice. We have a few MOAs working with us. Lacey is our CDM, a chronic disease nurse. We have maybe 1 or 2 other nurses. I think 1 other nurse working with us. And we all work under the same roof. And we're just privileged to be able to work that way. We have the PCN office not too far away from us. And through this project, we're able to advocate for a social worker in the PCN that we can navigate patients to. Now, over the years, we've been able to improve the capacity within our own clinic to identify and to navigate patients that have social determinants of health, impacting their health. So teamwork, again, is extremely important. The reason why I had to go through that quickly is we work in the North Zone. In the whole of North Zone, all clinics are fee-for-service. There are only very few BCM or ARP clinics in the province. So most physicians actually work for fee, work in a fee-for-service environment where you have you don't have enough time. There's time constraint, there's limitation in team support. So it's quick in and out in most places. So a lot of physicians truly don't have enough time to open this kind of one. But if you have a team that is trained and supporting you, it makes it much easier. What we embrace, what we have built into our clinic is, those three things we talked about earlier. Ask what matters, listen to what matters, and do what matters. We have our MOAs, for example, trained on how to identify, or you're putting a patient in a room, you can, have a chat with them quickly, what's going on in your life or whatever. It's amazing some of the stories that some of the medical office assistants actually tell you that patients are not able to tell you within the short time you have with them. If you look at that video again, I just saw it again, actually, it's as if I didn't see that part before. The arrangement in that of our sitting positions in that video, Lacey was sitting and I was sitting, and I don't know how many doctors actually have the privilege of doing that. We actually, both of us, we actually saw a patient together today. It was exactly the same position. Having a team member working with you with the patient in the same room, it opens a huge opportunity for the patient to talk about some deeper issues. So team training, team support, I think is very important. Some of the things we have done in our own clinic, for example, we have the girls have, well, I say the girls, all our staff, they have T-shirts that say, ask me first, So imagine a patient coming to your clinic and they see on all your staff, ask me first. They probably, what's that about? And I mean, and the reason behind that is to encourage patient to ask staff any questions. It doesn't have to be the primary care physician. We have posters, for example, that highlight the importance of, social determinants of health. I know some clinics have used QR codes before, and I think there's a clinic in Calgary that does that. And we have key rings from engaging with our community partners in the past. We've been able to map out different community resources, and all our staff have those key rings that have information, fax number, phone numbers, to housing, to addictions, to mental health, to employment services in community. So if a patient comes, and you think a patient has a problem in a particular area, it's easy for them to navigate a patient. So again, teamwork is extremely important. No one person can do this alone.
Yeah, absolutely. Now, Lacey, is there any examples that you would share in terms of how you inspired the team?
My role in this work was empowering the office assistants who have a day-to-day interaction with these clients. When we were working through how to make the biggest impact with this work, we ended up flagging these patients so that it would show up on our EMR when these patients arrived as RIFs patients. So if they were previously screened and they were positive and we had attached them to resources, or we were kind of in that conversation, the office assistant, it kind of just brought it to their, to the forefront of their mind when they were rooming the patient to be, to touch base with them. Hey, we worked at gathering names that were on the other end of those community resources that they might have been referred to. And then just to touch base, how are things going? And how are you doing? And listening to actually hear what the patient had to say, how they were going. And it really was remarkable, as Dr. Joseph said, the different types of information that the patients would share with the office assistant that was just, greeting them kindly as they were entering the room, rather than, even some of the information they would share in the room. So when that just blanket of grace and understanding was mimicked with all of your office staff, your receptionists, everyone that kind of came into contact with, it had them feeling like they were part of that team, that they could approach you for whatever needed to be. And I mean, this extends to all of our patients, but we did try to specifically point that out with our risk patients to ensure that they were supported along the journey. And if they needed a warm handoff to a support services, we were there to offer it and facilitate that.
Wow, that's great. I think one of the elephants in the room is sort of that the fact that primary care teams are already doing so much. They might be feeling, how can I ask these questions about financial strain, food insecurity? To your point, Dr. Joseph, I'm going to open up a whole can of worms that I can't solve or will take so long. What advice would you give?
Just asking. I published a research several years ago about helping people to quit smoking. The most important intervention to quitting smoking is just asking patients. And the same thing goes for social determinants of health. Just asking the question, how are you doing? Or what do you think is really going on? For example, the lady I talked about yesterday, that was how. Okay, yeah, we've done all these tests. What do you think is going on? And yes, some people can feel a little intimidated by that and feel, oh, no, what's going to come out? The truth is that if you don't ask and you're not able to identify all those, you may never be able to get to the bottom of the problem. Patient keeps coming back. Patient is not satisfied. You're not satisfied yourself. But I think the most important thing really is just asking that question. And the good thing about it is, if you ask and you think you need to dig deeper and you don't have the time, you can always bring the patient back. Many times I go back, I tell, do you know what? We need to have a deeper conversation, perhaps next week or in 2 weeks' time. Do you mind if we book a double appointment next time? Oh, patients jump at that. And, they really feel, those are the patients you actually keep for life, because they really feel the connection. They feel you were a good listener. You were able to get to the deep issues, affecting their lives. So I think the most important thing is really asking. And if you think, you're opening a big can of worms, then you can always bring the patient back. Or sometimes you call the patient, a virtual consultation. I just want to connect with you so that we can talk a little more about your loss of job that you talked about the last time. Perhaps there's something we can do. But the truth really is that most people, they have the solution in their hands, and the job that we do is to coach them to bring out the answer, to help them identify the solutions, not necessarily to do referrals or to try and jump into solving their problems, but to help them identify what the real issue is and what they feel the solution is. And I think that was what we actually did in this particular patient.
Yeah. Wow. Yeah. That's really great. And so you touched a little bit on my next question. So maybe I'll throw it to Lacey. Can you share practically how you addressed social needs within your clinic and PCN, and what role the team played? I know you've talked a little bit about this. Is there anything you want to add? And I know there was some great insights from the Slido comments as well, but anything else you want to build on there?
Yeah, absolutely. And I know it feels quite daunting when you're starting to have these conversations, because there has been some that probably have gone terribly, wrong, or where you felt like you're not doing enough for the patient, or you don't have any resources to add. I want to reassure that, when we were looking at doing this work and embedding it in our processes, we were doing a lot of work on the back end with our community partners, knowing what pathways that we were going to utilize for each of our screening questions. Yes, that wouldn't be every single positive screen for the RIF tool, but it would be the majority of the referrals. Like, for example, if we had a difficulty with medications, we would meet with the pharmacy. We would go over any compassionate care. If they had difficulties with transportation, we had a grant or a dial-a-bus grant that we could complete right in office. So they didn't have to go here and there to get signatures. We can complete the medical portion, send it right to where they're taking the grant applications. We had to find pathways for each kind of scenario. And then, like Dr. Joseph touched on, we had key rings that we used for the rest of our community resources. We could always refer on to our community navigator, but we had a good idea at the clinic level what kind of resources were available right now, so that we could hand off to those resources and the patient didn't have to wait for that referral to go through. We could get them started in office, in clinic, and that was a team-based thing, right? They would finish with the physician and then either come to myself or the office assistant would take over, depending on what depth of referrals needed to be completed. And then we would work from there. Having that good baseline of what resources were available, I think really helped empower us to have those conversations more often, because we kind of had an idea of what we could do depending on what they screened positive for or what their needs were. And I want to reiterate, if we didn't know the answer, we knew how to find them. We had enough external team members and community partners that we could leverage. Okay, I'm just going to parking lot this for a minute. I have a team member I'd like to reach out to. I know we haven't quite solved this today, but I'm going to call you tomorrow or later on once I've spoken to them and really get this mapped out. And sometimes just that warm, handoff of resources and having a plan that you were going to follow up with them, they were just able to, relax and feel like they were really taken care of.
Yeah. You've kind of touched on my next question, which I love. The whole community partners and citizens are doing so much to improve community well-being, and the amount of inspiring work that are happening in many communities across Alberta is quite remarkable. Tell us a little bit more about your work with community partners and what impact you've seen with your patients, your clinic, and in the community.
So yeah, I think we have been engaging with our community partners for a long time, and that has been very helpful with the way we support patients, because it can be really challenging. If you don't have the resources, then you don't really want to open the can of worms. You have to have a connection. I'll give you a quick example again. Today is Thursday. I think 2 days ago, a lady came into my office. She was like, "Why, Dr. Joe, why were you calling me? I was on vacation last week." And what happened was I was working in the hospital and I saw this lady that was homeless. Actually, it was around 6 a.m. in the morning. And she was brought into the hospital, RCMP and all that. And she was previously in the women's shelter, but, there was a history that she wasn't following rules and everything, so she was kicked out. So I had to advocate for her to go back, to be able to get back into the women's shelter. And the nurses were calling, everybody was calling, and nobody could get through. And I just picked up my phone. I just called the director of women's shelter, and because I know her, we've worked together, and she said, "Oh, Dr. Joe, I'm sorry, I can't pick your whatever, but I'm on vacation. I'm outside. I'm outside the country now. How can I help?" And I said, oh, don't worry, I won't disturb you on your vacation. But the point I'm trying to make is we have the connection, you know, and so we worked with, you know, a lot of our community agencies in town, from housing, from employment, even RCMP, addictions, mental health, the food bank, lunchbox, men's shelter, women's shelter. Sometimes we've actually invited patients with their families and their landlord for conference meeting in our clinic. You know, you have like 6-10 people come together. Okay, this guy is homeless, or cannot pay his rent. Landlord, what can you do? How can you help this patient? We can guarantee this is, you know, do you understand what I'm saying? So I think it's very important as healthcare providers to know the resources that are available in our community, and not only know those, but work with those people on a regular basis, have a connection with them. So you can just give them a call. Look, employment services, it's Dr. Joe on the line here, please. I have a problem. Can you help me with the guy here? He's really keen to work, but he can't seem to. What can you do? Oh, Dr. Joe, I'll do that for you. You know, that's something that we do commonly in our community. So those are some of we've attended community town halls. I think we had a meeting recently about housing, I think a few weeks ago. And we work even with our pharmacists in our community and all the pharmacists on a regular basis. So working with community agencies to even know what they're doing, what they are able to offer patients, it's really important in order to be able to navigate patients appropriately.
Wow. Yeah, so really using your influence. That's powerful. I'm wanting to just direct my next question to Dr. Luanchek. You've been listening in and seeing some of the great responses from participants, and just acknowledging the notion that primary care cannot do this alone. We're hearing some great examples of that. I wonder if you can just share your insights into potential system supports.
Well, we've heard some really good examples and possibilities of what can be done, and heard the importance of relationships. From the systems perspective, then, one of the things that we can do, and we'd like to be able to do then, is support the ability to create those relationships, the ability to meet the needs or address social needs of people. So it's not something that a physician practicing in isolation can do, as we heard. So there's a number of things. One of the things that's on the table with the new MAPS initiative, or Modernizing Alberta's Primary Care System, actually speaks to this. So it does identify the importance and the need of addressing social factors. And so that goes along with enhanced team membership and funding for practices and primary care networks. So that's a necessary component. So that helps provide the infrastructure and supports to enable things like this to be done. But also at higher levels, and whether it be, at a local zone level, or at a local town, city level, even provincial level, things that we can do are to help also facilitate and create those relationships with the various not-for-profit, volunteer, charitable organizations that are involved in this sort of work, or to whom we refer, with the various government ministries, particularly FCSS, who also helps tie together the volunteer sector, the municipality, and the medical, potentially, dealing and creating relationships with municipalities who can also help to address needs or identify gaps in care, and then helping to facilitate through our Healthier Together process within AHS that the collective impact approach, or looking at asset-based community development to identify, what resources exist, what the strengths are in communities, and then helping them to develop those or to make maximum utilization of those. So there's a number of ways in which the system can help behind the scenes facilitate all of this great work.
Yeah, fantastic. I'm seeing some great comments in the chat, and maybe I'll turn it over to Kally, and she can field some of your questions that you have for the panel.
Okay, I'll just take a look at what we have, and yeah, so thank you so much again for just sharing your stories, and the idea of relationship really, just the importance of relationship really stood out. Relationship with the patient, the clinic staff, the community, and also the relationships we can build together as a system. Just scrolling through the different questions. Just take away. Well, yeah, I see there's a comment about how, yeah, just everything's so interconnected. And that it's not just the cost of, food, but it is the cost of just all basic needs that some families are balancing and having things covered. Just here's a comment about, yeah, just thinking about how costs will be covered, how they can get to certain locations for appointments, and paying for things like parking. And it just, really thinking about, what are some opportunities for us to work together to reduce these burdens for patients. Okay, taking a look here and seeing someone remarking about just the importance of assessing socioeconomic risk to be effective. And a social worker on the call as well. Just really sharing their services with us. So
Yeah,
most of what I see is in the comments. Shawna, are you seeing any other questions?
Yeah, no, I think the point about social workers being on the team, I wonder if maybe the panel could sort of speak to that, because I know there was a number of teams who did not have a social worker, and that point that unfortunately every PCN cannot, or even if they would like to, cannot hire, due to recruitment. But I wonder if the panel wants to just comment on, sort of the makeup of the team and the inclusion of a social worker.
Personally, I feel where there's a will, there's a way. It's difficult for me to appreciate that any PCN cannot afford a social worker. I think it's a matter of the PCN understanding why it is important. Why, again, for us, for example, to do this project a few years ago, we had to advocate for it. Actually, I remember kind of halfway during the project, when we were having difficulty recruiting a social worker, I told, I'm sorry, I can't do this without a social worker. Forget about it. And yeah, then they took us serious. Okay, if you need a social worker to do it, then since then, we've had a social worker in our PCN. So I think, like Dr. Richard was saying, at system level, this is something we need to be advocating for. There's no way it's going to be, our healthcare system is very complex, and most patients cannot navigate the web. They can't navigate the complexity. They need a community navigator, a social worker to help them, navigate the system. Who do you need to see? What forms do you need to complete? Is it age you need? Is it income support you need? Is it medication assistance you need? Where is the employment services? Where, most patients, remember, these are vulnerable patients. And when they are vulnerable, they can't even think. Many of them cannot even think well. They need some hand holding. So again, at system level, this is something I will strongly advocate for. Every PCN needs at least one social worker. And of course, larger PCNs need a few social workers. Again, it comes down to what we said. Most of the medical problems we are facing have social determinants of health in the background. And we need, in medical school, we are trained to treat, medical problems, biological problems, not social problems. But today, most of the issues we are facing, the root cause of them, most of them is social problems, social issues. So we definitely need social workers.
To add to that, we just had a 1.0 like full-time FTE for our social worker, and we did find that there was a bit of a funnel at her services. So what we did was develop some innovative pathways alongside of her, so that if we had patients that screened in a specific way, we could just attach to services and get patients started, so that when we touched back with those patients, if they needed additional supports, then we could refer to her, or B, when she followed up with them, they were already well down the pathway to being supported, and so it wasn't such long consults that were needing to be. But as Dr. Joseph said, where there's a will, there's a way. There's a way to do almost anything if you can, and that's how we worked with the limitations within her time with our PCN.
Yeah, that's excellent. Dr. Lewanchuk, I wonder if you want to build on that and maybe speak to, I know one of the questions previous was social prescribing, but if you want to build on that conversation.
Sure. Yeah, I was going to add, the experience in other jurisdictions that has been sort of exactly what Lacey has just articulated, is that some people's identifying the needs, some people's needs are fairly simply addressed. And so in the NHS in England, for example, that they have the linkers who link people with the services, but there's others. So some data shows, for example, a family that's with a lot of trauma can be interacting with up to 25 different agencies, social agencies. So it can be very, very complex. So there are some things that can be functions that can be carried out by community health navigators, and others that need complex case management, which is probably best addressed by a social worker, or a social worker as part of the team can help quarterback, those social activity parts of the practice as well. So we have been actually working with our AHS social work group, who would love to be out much more so in the community and supporting. We've also been dealing with the faculty of social work at the University of Calgary. That's the only faculty in the province. They have a branch outlet at the University of Alberta about training more social workers. And then, as I said earlier on, part of the consideration is providing the resource to be able to then hire those individuals.
Yep. Wonderful discussion. Such rich information. Thank you so much to all of you for sharing. And I'll pass it over to, I'm not sure if it's Kally or
Denise for your closing remarks.
Yeah, no, fantastic. I think everyone's thoroughly appreciated all the innovation that's happened with your clinic. And thanks so much for sharing the stories. And just really good to have these practical resources as well that we can use, and ways of sort of directing that future of primary care. I'm struck by, even though I'm part of a really large PCN, we have a relatively small number of PCN team members. And so I worry that the burden that we see of people who need support is far outstripping the number of people that we have. But hopefully this is a really good direction. So thank you to all of you. And I think we'll be sending out these recordings and pearls and stuff. And so if people have additional resources and things, hopefully this will be start of a really good conversation. So thanks to all of you for all of your time, and have a good afternoon clinic, everybody.
Thank you for having us.
Oh, no, thank you for coming. It's fantastic.